Hello, my fellow residents. So, today I'll be telling you how to differentiate the acute kidney injury, whether it is a pre-renal, renal, or a post-renal, through the investigations of the patient. So, we only need two investigations, that is the renal failure test that we usually do, what is called as RFT in the patients, is and in that we need the serum creatinine and the blood urea nitrogen. Yes, I'm right. Only with these two values you can understand whether it's a pre-renal, a renal, or a post-renal. So let's consider that we are taking the ratio of blood urea nitrogen and serum creatinine. Ideally, this ratio has to be between 12 to 20, which is considered as normal. But if this ratio is 15, that is also an optimal normal level. Now, through this ratio, how can we know whether it's a pre-renal, renal, or a post-renal AKI? Basically, if it is a pre-renal AKI, the ratio of blood urea nitrogen is to serum creatinine will be high, on a higher side, that is more than 20. So what can be the causes of pre-renal acute kidney injury? So it can be either a high protein intake, a gastrointestinal bleed, or it can be vomiting or diarrhea. Now let's consider that this same ratio, that blood urea nitrogen is to serum creatinine, in some other patient it is low, that is it is less than 12. So what can be the cause of this is nothing but a renal AKI. That is, the cause can be within the kidneys. It can be a interstitium involved, a tubular function and disease, anything within the kidneys. We consider that it is a renal acute kidney injury with the ratio of blood urea nitrogen is to serum creatinine being low. But let's consider that this ratio of blood urea nitrogen is to serum creatinine is high, along with a high serum creat. Then what can be the cause? Then this is nothing but, my friends, this is a post renal AKI, that is acute kidney injury. And what can be the cause of this post-renal AKI? It can be anything from obstruction to a congenital obstruction, a posterior urethral valve, or there can be a stenosis, there can be a fibrosis, or because let's consider that there have been some strictures. Now, what are the managements depending upon what type of AKI it is? So, whenever there is an acute kidney injury suspected, we assess the child, whether the child is dehydrated. We check for the pulse, whether the pulse is bounding. If the pulse is bounding, it's nothing but, guys, it is a low volume pulse, and which can be felt very easily. Then what next we check is the blood pressure. So if a blood pressure is low, it is the hypotension. And we also check for the saturation level, whether is there any hypoxia or anything. We also check whether the patient is on any nephrotoxic drug. So we have to remove all these nephrotoxic drugs, or we have to adjust the dose of these nephrotoxic drug accordingly. So I'll tell you how to adjust this drug. First, coming to the part like, if there are any nephrotoxic drug, you have to check this. And next is what we have to send it in the investigation. We have to send the serum electrolyte every 6 hourly, and we have to make sure that we are doing the body weight 12 hourly. And now, coming in next part is what we do else apart from this. We have to palpate the per abdomen, and we have to check whether the bladder is palpable or not. If the bladder is palpable, the most common which we think is that there is some obstruction, and because of which the new urine is getting collected in the bladder but it's not getting empty. There can be a stricture, there can be a stenosis in the urethra. So how to consider? Like, let's consider that where if the bladder is palpable, then there has to be an obstruction. The obstruction is at the level of the urethra. So you also got the location as well. And here we can know whether the posterior urethral valve is causing the obstruction, or stenosis, or there is a stricture, anything. We have to further evaluating depending on the further investigation. But what now we can do apart from this? We have to also assess how is the cardiac function. We have to do if there is a portable sonography machine present, we can ask the you can also do, if you know, or you can ask your consultant radiology friend who can help you out, telling how is the cardiac contractility, how is the volume status of the patient, and also check whether you can feel the liver. In case you're feeling the liver, then there's a sign of congestive cardiac failure. You can also hear whether there are any basal crepitations present. So these are all things which you have to keep in mind. Now, how to manage this case? So before that, if it is a pre-renal AKI, what you can do? Pre-renal AKI, as I have discussed, the cause can be anything. It can be because of a dehydration, because of a vomiting, because of a diarrhea, or there can be a starvation, anything in this line. So you just increase the 10 to 20% of the total fluid requirement per day, and you can just manage the pre-renal AKI. Just friends, don't forget that you don't have to add a bolus. If you are considering, if you're adding a bolus, you're giving just for that time being. But if you're adding the fluid over the 24 hours whole as a perspective, then you're giving the fluid entirely over the 24 hours, and this will help you manage the AKI much better, and just not giving small short bolus, because that will land into insufficient. You yourself can calculate, if you're increasing your total maintenance daily fluid by 10 to 20%, and you calculate that volume, and you calculate the maintenance fluid plus the boluses which you are giving, so you know the difference, that much better is increasing the 10 to 20% of the maintenance fluid for a pre-renal AKI. Now, what to do in a case of a renal AKI? In that, you have to calculate the insensible water loss. So what are the various ways where the insensible water loss can occur? It is through our respiration, that is through our lungs, through our skin. In There are various forms. So how to calculate? So for this, you must know what is a body surface area, how to calculate the body surface area. This formula is nothing but it is a Mostellar formula. So what exactly we calculate in this body surface area formula, that is this Mostellar formula? It is nothing but must know the weight of the child in kgs, the height in centimeters. So you have to multiply the weight of the child in kgs into the height in centimeters, and this value you have to divide it by a 3600, and this, whatever the value which you are getting, you have to make a square root of this value, you get the body surface area. Now for a renal AKI, you have to multiply for 400 into this body surface area to get the value of the insensible water loss. But now this insensible water loss, whatever ml which you are getting, it is you are getting for around 24 hours. So first you divide it, that you can, if you divide it by 2, let's consider you are giving the half in 12 hours and the next half in the next 12 hours. But why I'm telling you to divide? So let's consider the patient just comes up to you, and he is having a you have done the investigations, you have calculated the blood urea nitrogen, you have calculated the serum creatinine, and now you know that this patient fits into a renal AKI. But now, what to do exactly when this patient is fitting into a renal AKI? You have calculated the body surface area, but you don't know the urine output. Ideally, the parents don't, none of us measures the urine output, whether it's going in a good, and some, there is a factor of patients might not knowing it, or the parents have not been knowing what exactly is the urine output, whether it's a good or less, they can only tell this. So you have to make sure that you have calculated this urine output in ml. So you just calculate the entire urine output for the 12 hours, and then, and so this, whatever you have calculated in the first 12 hours, where we are giving in the maintenance fluid plus the insensible water loss for the first 12 hours, in that you calculate the urine output. So this urine output ml you add it on to the next 12 hours. So now for the fluid for the next 12 hours will be the insensible water loss, the maintenance fluid plus the urine output in mls, whichever whatever amount it is, and that you can give. So now let's consider in case of postrenal AKI. So in these cases, you already know that the your kidneys are properly excreting the water, everything is getting excreted out, but there is a problem at an obstruction level in the urethra, or there can be an obstruction anywhere at the point of the junction where the urethra and the bladder is in continuity. So in this case, you don't have to give any excess of fluid, you just have to do a surgery reference and ask them whether what we can do ahead. or you can do a bladder catheterization and drain out the urine out volume. But now let's consider that a renal AKI or a pre-renal AKI. In this condition, what you can do? You have to give a NS bolus of 10 ml per kg over a period of 20 minutes. Along with this, I'm saying along with this, of NS bolus, you have to give injection furosemide as well as 1 mg per kg in an infusion over the 20 minutes. And now let's consider what is the urine output. If the urine output is less, then it is definitely a renal AKI. And if the urine output is more than 1 ml per kg per hour, then it is a pre-renal AKI. So always, my friends, furosemide is only to be added when there is an oligemic renal failure. Oligemic means the urine output is less than the requirement for the age and as per the person. And what is non-oligemic renal failure is that the urine output is more, and so the furosemide is not to be given in cases of post-renal AKI. This has to be kept in mind. Giving a furosemide, it's a negligence in a post-renal failure. So I hope you understand this. And do you understand why I'm emphasizing more on how to treat AKI based on blood urea nitrogen creatinine? You get to know what it is exactly, how to manage each cases separately. You further have a further line of management after this. You have to adjust the dose of the nephrotic drugs if you are using as per the nephrotic range. So for that, how you have to do? So basically, you have to calculate an estimated GFR. How to calculate this estimated GFR? It is nothing but K into height in centimeters divided by serum creatinine. So this K is nothing but it's a constant. In case of preterms, we consider this K as 0.33, and in case of infants, we consider this K as 0.45, and in case of children, that is from 1 year to 18 years, we consider it as 0.55. I just hope that you have been very much clear about this, and based upon this estimated GFR, you know how much percentage of the nephrotic range of the drug you can go, whether it's a 50%, whether it's an 80%, or you have 100%. And these dosing are being given in best books like the Meherban Singh, or you have everywhere. There is a charting of how you calculate the estimated GFR drugs for each and every office. This you also can find in AIMS protocol of NICU. And now, how to know what is exactly a GFR? So GFR is nothing, my friends. Estimated GFR is nothing for a normal person. It is around 80 to 120 ml per minute per meter square. And now I hope you have learned out how to calculate this estimated GFR, how you have calculated whether it's a pre-renal, a renal, or a post-renal. I don't say your management just ends by giving a NS bolus or a furosemide. You have further steps, but I have just given you the line of thought how you have to think when you are getting a person with a decreased urine output. You are suspecting it as an AKI. I just hope that you have liked this video. If you have, please share it among your colleagues, spread the word, and also with the residents. This is very much helpful in your first year of residency and the MBBS students who are just currently into practices. These videos are very much helpful. I just hope I'm making such more contents, and you can pin down whatever you want to know in the comment section so I can help you out on those topics as well. So if you like this video, please give a thumbs up and subscribe to the channel. I hope I am helping you out. So this is Dr. Hemangi Reddy.